And thank you again, once again, for joining us.
You bet. So again, thank you for the honor and privilege of presenting to this group. My topic today was to talk about brain tumor care in terms of horizons, what we're looking for, we can look forward to in the near, mid, and long term. So what is really basically going to cover is diagnosis, treatment, and follow-up in terms of what we can look forward to in terms of advanced care. But partly I wanted to do is demystify brain surgery to a certain extent. And I think even for my physician colleagues, neurosurgery remains a bit of a black box. There seems to be a lot of purple curtains with wizardry going on behind the scenes. That's hard to understand, but really from, I think, my point of view and my colleagues, what we do is similar to what most people do either in their work life or in everyday life, so that a physician or a neurosurgeon on a day-to-day basis involved in diagnosis, treatment, and then organizing follow-up. And I think everyone in the audience can relate to that, because in your work life or even in your personal life, you will deal with problems. So a family member, a workmate, a friend will come up to you with a problem. And then as you define that problem, you work to repair the problem. And upon repairing the problem, you then, what I would call is put in place a warranty. In other words, you want to make sure that the repair is still working, that it's sustainable, and to have a contingency plan if the problem recurs. And that's essentially what a doctor does, and certainly what a neurosurgeon does. And hopefully in explaining that way, it makes what we do seem a little bit more straightforward and logical, and importantly understood. So I'm just going to briefly go over the current best management of diagnosis, treatment, and follow-up. And I'm careful to use the word best management as opposed to standards of care. I think there's the connotation of standard is average, and if you do things in a standard or average way, you'll have standard or average outcomes. And of course, we want better than that. So I think the better term to use for what we currently do is best management. So as Gary described, in terms of diagnosis, imaging is done primarily through CT and MRI scans. That's current best management. Following that, tissue is sampled and brought to a pathologist who will examine it under the microscope. It'll be stained over 1 or 2 days, and it will also send the tissue off for molecular, genetic, and mutation analysis, which is very helpful in determining the type of tumor. So again, it just goes back to defining the problem, and the more details you have about the problem, the better the solution that you can find. So there is a triumvirate of treatment for glioblastoma, or any glioma really, and again, Gary described it very well. It involves surgery, radiation, and chemotherapy. The best way to describe our philosophical approach to surgery is maximal safe resection. And so if you can remember that description, maximal is obvious. We try to take out as much of the tumor as possible. The caveat, of course, is that, well, we want it to be safe. In other words, we want the patient to leave the operating room in the same good condition that they entered the operating room. So that will limit how much tumor can be taken out. So ideally, you can take out all of the tumor, and I'll give you a caveat on that as well, and preserve all neurologic function. But there will be times where that is not possible. So for example, if the surgeon said I was only able to take out 80% of the tumor, that typically means that the 20% that was left, that its removal would have caused a neurologic injury. And so it was left behind to hopefully be controlled by chemo and radiation therapy. So maximal safe resection is the philosophy for surgery on cancers of the brain. Again, Gary described his experience with temozolomide, which is the current best chemotherapeutic option to battle gliomas and certainly glioblastomas. But there are a short list of other drugs that can be used if for whatever reason temozolomide is not tolerated. And radiation is given, it's not given to the entire brain, but it's given to the original size of the tumor with a 2-centimeter margin around that original outline. Of course, radiation is high energy photons, which are invisible but sweep through the brain. And the dosage is given such that it causes death to the tumor cells, but it doesn't injure the normal brain. So that is the limitation, of course, is radiation. A high enough dose can kill any tumor, but if it's too high, it can also injure normal brains. And then again, Gary described it very well. Follow-up is typically serial imaging and examinations roughly every 3 months. And then treatment for recurrence is usually only decided upon at the time of recurrence, not typically done in advance. So that's a quick summary of the best care currently deployed for glioblastoma. But I wanted to spend the bulk of this talk talking about horizons, what we can look forward to. Some of them are already in place. Some of them are going to come up over the next months to years, and some might be further down the line. But I think it's a good sign of optimism and hope that we can look forward, that there are things being done actively to improve the outcomes. So as I said at the beginning, the first issue is diagnosis, and that is getting to the root of the problem. So we'll often have problems at work, or we'll have a friend come to us with a problem. And the first thing that we normally would do is to ask more questions about the problem, to get more details about the problem so that we can provide the best solution possible. And Gary described symptoms of numbness, and then there were flu-like symptoms. And of course, we as physicians try to fix those symptoms, but more importantly, we're looking for the cause behind those symptoms. And in this case, we're talking about brain tumor. But to simply describe the cause of brain tumor isn't enough. We want specifics. And in that regard, we want to know what the specific type of brain tumor that we're dealing with. So again, the theme here is the more we know about the problem, the better the solution we can propose. And towards that end, of course, CT and MRI are very powerful in providing that information on the tumor type. But currently on the horizon, in fact, it's more than the horizon, but we're applying machine learning or artificial intelligence to help us define from a scan the type of tumor that a person is dealing with. So we're all familiar with machine learning, whether you know it or not, right? So whether you're on Amazon or Netflix or YouTube or you're Googling, we're familiar with it giving us suggestions about our preferences. And so Amazon will suggest products that you might be interested. Netflix will suggest shows that you might be interested in. And this is all based on machine learning. In other words, it's observed your behavior from the past period of time, and then it's processed all that information and come up with a prediction of your next step, your next behavior. So that can be irritating. It can be kind of creepy at times. But if you applied that machine learning to brain scans, you can see how it can be very powerful. So that a radiologist might remember 1 to 200 or maybe 1,000 scans that he's seen before. He's able to do certain measurements on those scans. And then he can look at a patient scan today and try and correlate that scan to the ones in his memory bank. Well, a machine can remember millions of scans and do thousands of measurements. And so its ability to learn and predict is going to be much more powerful than a human. So I think machine learning is going to be a powerful aid in the world of diagnosing brain tumors. And that's especially true if there is not an expert neuroradiologist in your vicinity, which is very often the case. We are working towards a world where we can replace brain biopsies by images using machine learning. And even if that can't quite get us the same information as a tissue analysis, it might be enough at least to plan treatment. So as I described before, the next facet of diagnosis is actually getting tissue samples and analyzing. And again, where we are today is to put gliomas into 4 broad categories, graded 1 to 4, and a glioblastoma is grade 4. But just like it's not adequate to describe humans in general categories, we want to assess them on an individual basis. This should also be true for tumors. In other words, I think it's less important what category the tumor is, and it's more important to know the specific genetics, mutations, and biomarkers of an individual's tumor. It's generally helpful that it falls into a certain category, but it's way more helpful to know the specific profile of that tumor. And again, this is where machine learning can be very powerful. So if you look at the background of this slide, you see an actual histologic microscopic picture of a brain tumor. So a pathologist can look at that and he can see the shape of the cells, it can see the color of the purple, it can see the arrangement, and based on previous experience, make a prediction of what kind of tumor this is. But again, a computer can do this in a much more powerful way, looking at millions of similar slides and doing thousands of measurements that a human couldn't do, and making a much more accurate prediction of the behavior of this tumor, and also being able to make a prediction on what kind of therapies would be most effective. Blood tests are another avenue on the horizon that we're exploring to detect brain cancer. There are a handful of other cancers that can be detected through a blood test, but as people in the audience know, this is not yet true of brain cancers, which is certainly a limitation. It'd be way easier and faster if we could detect brain cancers through a blood test than having to go through an MRI scan. So again, this is on the horizon. Another area of diagnosis that's important is tumor tissue banking. So all the tumor tissue that's taken out from surgery goes to the path lab. And in most places in the world and in most places in Canada, that tissue is put in wax and then it's analyzed. Now, when you place the tissue in wax, it loses a lot of its very important genetic and biomarker material. So a lot of banking takes place for tumor tissue, and there's only a few places in Canada where this takes place. But by deep freezing the tissue, you preserve a lot of the genetic material and a lot of the biomarkers that may be important in the future. So for example, if you go through treatment and after a year or 2 or 3 years, there's a recurrence and there's a new therapy available, but it's dependent on a marker, you can take that frozen tissue and analyze it for that marker. Whereas if it was simply sealed in paraffin or wax, those markers would be long lost. Another advantage of tumor tissue banking is that we can create what are called cell lines. So in other words, we keep those cells actually alive and they continue to proliferate and grow in the lab. And again, there's a theoretical advantage to this. So if the tumor, say, recurred in a year, you can look at the cell line of that specific patient and then start testing drugs against it to see which drugs will work or won't work in the lab instead of having to test it on the patient themselves. So there's very obvious advantages to tumor tissue banking, which hopefully is going to become more commonplace across Canada. So hopefully you've understood how we're doing more and more research and work and innovation on diagnosing the problem, figuring out with a lot of specificity what the problem is. So the next stage after you've well-defined the problem is treatment. So I'll go into the horizons in treatment, but I need to give you a little bit of context about why it's difficult to cure cancers. And there are 2 things to understand. And the first is the blood-brain barrier, which I think a lot of people might understand. And this is a simple concept that blood or the blood vessels in the brain prevent a lot of drugs from getting into the brain itself, so that you can give a person a drug either intravenously or orally, and then it's absorbed into the bloodstream, and as it channels through the blood vessels of the brain, it can't get across the blood-brain barrier and into the tumor tissue. So this is a big problem in neuro-oncology. We know that there are a lot of drugs that are very effective against glioblastoma in theory in the lab, but they can't get penetration through the blood vessels into the tumor. So the blood-brain barrier remains an obstacle to cure. Another difficulty that we have in curing brain cancers is this concept of invasiveness. So hopefully my laser pointer is working, that If brain tumors were simply a lump, a collection of cells, a surgeon could cure that by removing all of them. The problem is that by the time a patient comes to attention for treatment, there's invasion of other cells from that lump that spread in deep into the brain, sometimes across to the other side of the brain. And these cells are almost invisible to an MRI scan for the most part. And that's why surgery by itself won't cure brain cancers. As I said, a surgeon can remove this lump of tissue. A laser can eradicate that lump of tissue. What it can't often do is track down all these migrant invading cells that infiltrate into very important parts of the brain. So again, if it was just a lump of tissue, you could remove it. Or if it was a large part of an organ which could be safely removed, so that could be true, for example, with colon or liver or breast tissue, where you can be very aggressive and get large margins on the organ to remove the invading cells. This is obviously not true for the brain. And so these are two important aspects to remember as you're thinking about why have we not yet cured brain cancers. But indeed, there are innovations and technology and research that are going towards overcoming this problem. So really the current best care involves neuronavigation, which is like a GPS for the brain, which allows the surgeon to approach the surgeon with confidence with relative to other anatomy. We sometimes do awake surgery to make sure we're not causing any neurologic deficits. We have very robust neurologic monitoring of motor function, speech function, and vision as we do surgery. I believe Dr. Sinclair gave a lecture on fluorescent staining in glioma surgery last year, which is another way for a surgeon to differentiate normal brain from the tumor cells. And we also have fiber tracking, which shows us the fiber tracks of the brain as we operate. So those are all best practice currently. I think a lot of the audience might know from previous lectures that I introduced laser treatment of brain tumors to Canada. And now that technology is growing and that there are more and more sites across Canada, typically at big academic centers, that deploy laser treatment to eradicate brain tumors without the need of surgery. And then another aspect of surgery that's being introduced is implanting the drugs right on the surface of the tumor. So again, if you think about the blood-brain barrier and it preventing drugs from getting from the bloodstream into the tumor, that it makes sense, then why don't you at the time of surgery just apply chemotherapy or other treatments directly on the tumor, thereby bypassing the blood-brain barrier. And in fact, this is an area of research that is aggressively being pursued. So that's the horizons for surgery and surgery technology. In terms of chemotherapy, I can put it into three broad buckets of hope. And that would be in the realm of new drugs, new combinations, and new applications. So there's a long list of drugs that are currently under trial and be investigated throughout the world. Drugs which have different mechanisms of actions. A lot of them have been discovered through research labs or by pharmaceutical companies. A lot of them, however, are what we call repurposed drugs. In other words, they're drugs that have been effective for other cancers of the body, and people have thought that they should be applied to brain cancers. And there are other situations that there are drugs that are being used, for example, against parasites, which also have an effect on tumor cells. And those drugs are also being tried against glioblastoma. So that's in the world of repurposed drugs. Now, through the age of COVID, we've learned all about vaccines. And I think a lot of us now understand how vaccines work. So you take a tiny part of the COVID virus, not enough to cause a full-on infection, but enough to stimulate the immune system so that when it sees the entire virus, your immune system will attack it and kill it. The same concept has been applied to brain tumors. So if you take a portion of a brain tumor cell, not all of it, but a portion of it, and expose the body to it, that the immune system of the body will then learn to recognize that portion and attack the entire tumor cell if it's ever faced with it. And again, this is an area of ongoing research with several clinical trials going on. And similarly, there's viral therapy, and again, I think the world has learned about viruses and how they work, and we understand how they're contagious not only between person to person, but how they can quickly spread from cell to cell. Now, that aspect of viruses could be very important in treating cancers. In other words, to try and track down those invading migratory invasive brain cells, an easy way to do it would be to use the armamentarium, the weaponry of a virus, which very well can go from cell to cell, but then to modify the virus so it isn't harmful to normal cells, but is only harmful to cancer cells. And so again, you've probably heard about viral treatments of brain tumors, and again, an ongoing area of research that I think will uncover positive results in the near future. Again, I've talked about combinations of drugs. So not only are there new drugs, but a lot of the strategy these days is to combine new drugs with standard drugs, but also to combine new drugs with new technology and new technology with standard drugs. And then finally, in the world of chemotherapy, the application of drugs directly onto the tumor instead of trying to deal with the blood-brain barrier is an area of research that's on the horizon. So again, I think you're familiar with gliadel wafers, but there are other mechanisms of applying chemotherapeutic agents or anti-drug agents or molecules directly onto the tumor, thereby bypassing the blood-brain barrier. And then I'll get on to radiation. And to me, radiation is a bright hope for the future because, as I said, it's totally non-invasive, it's extremely powerful at killing cancer cells, regardless if they're in a lump or they're invasive through the brain. The disadvantage, however, is that the high doses of radiation can injure the normal brain. So a lot of research is being driven towards protecting normal brain from radiation, allowing higher doses to kill those invasive cancer cells. And indeed, there are new technologies on the horizon that I think patients that are newly diagnosed with brain cancers over the next year or two will be able to gain advantage through these technologies. So I've described previously laser ablation treatments. You might have also heard about focused ultrasound, which is a totally non-invasive means of killing tumor cells. You might also be aware of electric fields under the brand name Optune, which use external electrical fields placed on the scalp, which has an effect to inhibit or delay the growth of tumor cells purely based on electric fields. And again, by overcoming the blood-brain barrier by direct injection or infusion of anti-drug particles directly on the tumor instead of intravenously or by mouth. There are a few things that we're working on in the lab that I work with, but I think in the interest and time, I'm going to skip over these. It may be Janet will invite me another time to describe these in more detail. So the final aspect is follow-up. I talk about diagnosis, I talked about treatment, but follow-up is very important. And to me, I tend to call that plan B. And I think it's very important to develop a strategy very early on, not because you're predicting a recurrence, but you're prepared that if recurrence develops, that there's a plan already in place about what you're going to do. And a lot of that will be to instigate involvement into clinical trials. And so if I put this all together in what I think it should look like in the near future, it'll involve these bullet points. One will be prevention, so that we learn what causes brain tumors. So at that level, we can stop them from occurring. We need to develop our technology and expertise in screening for tumors, whether it's with early imaging or through blood tests, so that we can deal with smaller, less malignant tumors, because if they're smaller and less malignant, our success rate is significantly higher. We're working on diagnosis through non-invasive means, through machine learning, so that we can get more and more details about the problem that we're dealing with. I want our treatments to be much more individualized. So as I said before, it should care less what general category or grade that your tumor is, and it should be much more important the specific mutations of your tumor, its genetic markers, its mutations, so that we can be specific in terms of how it's best treated, whether it's through surgery, chemotherapy, or a dosage of radiation. There are ongoing advances in surgery, which are becoming less and less invasive and more effective in tracking down those invasive tumors. Chemotherapy, I think, can be very powerfully applied if we can test it on patients' tumor samples in the lab in a cell line, as opposed to quote unquote testing them on patients directly, but we only use drugs that we know are going to work. As I mentioned, I think radiation will be a very powerful tool going forward if we can find ways to minimize damage to normal brain. I think we will develop ways of monitoring brain tumor on an ongoing real-time basis that doesn't require a 3-month MRI scan. Because as Gary described, it's an anxious time waiting for the results of your 3-month scan, because during that scan, you don't know if the tumor's been kept dormant or if it's growing. I'd like to develop ways of monitoring tumor growth that are in real time, that we'll get data on it on a day-to-day basis. So we'll have an early idea of when that tumor is starting to regrow, if it is regrowing. And finally, I call it Plan B. I think very early on that if a tumor is to recur, I think we should already have in place a Plan B based on a specific tumor type, that we are ready to begin treatment as soon as that recurrence is identified. And then finally, I'd like us to be able to access clinical trials of new drugs and therapies for all patients, regardless of geography. So for example, here at the University of California, San Francisco, there are over a dozen clinical trials available for patients with brain tumors, and another dozen clinical trials that are in the works. So that could be 24, 25 clinical trials available to patients with brain tumors, but really that's only workable if you live in California or are managed by the UCSF group. I think in the ideal world, those clinical trials will be available to everybody in the world, and certainly across North America. So Todd, I will wrap it up there, and I'm happy to answer any questions.
Thank you so much, Dr. Toyota. I really appreciate you taking the time to giving us a good review of what is happening in neurosurgery and providing this information to all those who are attending today. We do have a lot of questions to go through. And while I get my share screen back, I did promise the audience that we would get to know you just a little more personally, but in the just looking at some time, I'm just going to spare you to 2 personal questions. And
Sure.
First, when did you know that you wanted to pursue your specialty in neurosurgery?
I actually have a discrete answer for that. I can tell you, I was 8 years old.
8 years old.
I have that
Yeah.
through a reliable source, someone with good authority. That would be my mother, who said at the age of 8, I expressed the desire to become a brain surgeon, but I think I kept it under wraps because it sounded a bit cliche, like wanting to be Batman. So I think it evolved over time. And I think at one point in high school, I wanted to be a fireman, which frankly is similar in the sense of not only helping people, but rescuing people.
Yeah.
So it was very early on when the seed was planted to become a brain surgeon.
Wow. Yeah, great. Thank you. What has been the most rewarding experience so far to date in your career?
Yeah, I always have made an analogy between athletes and surgeons, because there are a lot of analogies there, but it does differentiate in the sense there is no sort of playoffs in neurosurgery. There's no pinnacle of success in terms of winning the Stanley Cup or the Super Bowl. Instead, there are more moments. And so I would say, and I've said this before in other speaking engagements, that the most rewarding experience for me is walking from the operating room at the end of a surgery to the waiting room. Because I know in the waiting room, there's a lot of apprehension and worry about worst case scenarios. And in the vast majority of cases, I'm happy to say, I can walk in the room, I can see the anxiety, and I can dismiss that anxiety with the quick words of everything went fine. Yeah. And for me, that's the culmination of a lot of things, but that's probably the favorite moments of my profession.
Yeah. And then you must just see the immediate relief by hearing those
it's
few
visible.
words.
It's even audible. There's a communal exhale.
Yeah. Well, thank you once again for sharing your expertise with us. I'm going to go through these questions, but I just want everybody to keep in mind too that Dr. Toyota is not able to give any specific medical advice, and that these questions are going to be pretty general in nature. And if there are any questions, Dr. Tyler, that you're unable to answer, that's okay. And just please
Sure.
let me know.
Okay.
You really talked about the future treatments that will be available for brain cancer. Do you think that this will somehow take out the need for radiation? And the quotation here is the toxic, not radiation,
Right.
sorry, the toxic use of radiation chemotherapy. What is your perspective on that?
Yeah, I think, like in general, I always say that the goal of technology is to remove the need of the surgeon, right? So that you shouldn't need all my years of training and expertise to remove a tumor. It should be all automatic and simple and non-invasive, so that it's just a click of a button that either launches the laser or the ultrasound to get rid of the tumor. So I think I'm less able to predict a certain modality that we'll get rid of, but the general theme for all the modalities is to minimize risk and improve the therapeutic outcome, the percentage of tumors that we get rid of, because you can almost look at it as a percentage gain. Surgery removes a big hunk of mass of the center of the tumor. It can't get rid of the invading cells. Chemotherapy through the bloodstream can pick off a few more of those invading cells, but not all of them. And then radiation therapy hopefully then sweeps through the entire brain and specifically picks out the invading cells. The problem with all those therapies is that the risk and the benefit are too close. We need to get rid of the risk and increase the benefit. And so for all three of those modalities and any modality in the future, the goal is to minimize the risk and improve the benefit. And that can be true for all of those modalities that I described.
Thank you for that. Yeah, that actually answered quite a few questions with that. So I appreciate that response. With glioblastoma, typically it spreads very quickly. What are some things that we can look at in the future that may help with that detection, even before, like, is there something before symptoms occur, or is there something that you're aware of that will just kind of give us an idea that something is going on?
Right. So again, this is a big area of research. So one of them would be predictive, right? So I tried to describe how machine learning, which again, we experience on a day-to-day basis, is in effect in our daily lives. So even if you're typing into Google, it'll try and predict the rest of your sentence, right? So it's predicting on prior behavior of future behavior. So if we can make those systems robust, instead of waiting for the tumor to occur, we might be able to predict what that tumor is going to do. So if you just take the whole group of glioblastoma, grade 4, as a big bucket, it's impossible. Some might recur early, some might not recur, some will recur at the average time. But we tend to treat everyone in that large bucket. But instead, it would be great to have a computer learning, artificial intelligence to say, no, Mr. X, we know from the specific analysis of your tumor, it's going to recur in 18 months. So we're going to work ahead of time to preclude it. The second aspect is I tried to describe how MRI scans are our current method to detect recurrence, right? But you got to wait 3 months or 6 months or even 6 weeks to find out. During that interval, the tumor could be growing. Hopefully it isn't. But if it's growing, it would have been growing over that span. And again, that's kind of not acceptable to me as a surgeon or to the patient. Wouldn't you rather know on a day-to-day basis that there's activity? So for example, diabetes, you can test it every day, every hour to detect where you're at. And there are other diseases where you can do that through blood tests most commonly. So we are working, that's one of the areas of research that I kind of skipped over, of putting monitors right into the tumor that can monitor like lactate, pH, temperature, a variety of metabolic factors that could reflect tumor growth. And those monitors can actually send the information through Bluetooth to a phone and tell you that today, oh, your pH has dropped. That's worrisome. Let's get a scan. So those are two avenues, machine learning and online real-time monitoring, that I think are the future for figuring out what a tumor is doing or not doing versus waiting 3 months for your next MRI scan.
Thank you for that. Yeah, that was great. Looking at glioblastomas and the possibility of this or these tumors being inherited, have you seen any research or any information linking these two?
Yeah, the vast majority of brain tumors are not generational. They're not genetic in that sense. And that's why there is confusion when we talk about the genetics of the tumor. Sometimes people confuse that to mean that they're hereditary, which is not what it means. We're just talking about the specific genes of that tumor cell and what the chromosomes look like. So when we talk about genetic mutation, we don't mean it in the sense that it's familial, that it's passed on. There are a very small number of syndromes where brain tumors can be common, but in the vast majority of times, they are not. Like I'm talking 99+%, they're not familial, they're not passed on. And there might be an uncle and then a nephew, but that's typically more coincidence than it is actually genetically based.
I see. Okay. And what about a diet, like something like dairy, sugar, gluten? Some people, and there's information online that says, "Oh, this feeds cancer." What is your scientific expert's opinion on this?
Yeah, and sadly, Todd, I don't have scientific. I can give you my impressions just through decades of working with nutritionists, reading papers and dealing with patients. And I know one of them has to do with glucose, because cancers, their energy is glucose. So that's, I think, where a lot of the common strategies, oh, get rid of glucose from my diet. The problem, of course, is that our body also uses glucose. Right. So it becomes an issue of the treatment being as harmful as the disease. Right. Yeah. Having said that, the diets that are ketogenic or minimize the load of refined sugars makes common sense. Even if they don't have an anti-cancer effect specifically, and I'm not saying they don't, but if they didn't, there's still a benefit to overall health that improves our ability to withstand radiation, chemotherapy, surgery, and can in fact bolster our immune system to combat it. I didn't talk about immune treatments for brain cancers, which are also a big wave of research. And so that's where I think diet becomes important. It may or may not actually impact the cancer cell that's there, but it can certainly impact our ability to fight that cancer or build up our immune system or tolerate treatments that are otherwise very hard on the body. And so I'm not smart enough or experienced enough to prescribe a specific diet, but I can tell you that when I've been the odd patient who insists, I will often suggest a ketogenic diet.
Okay. Yeah, thank you for that. I appreciate the clarification. Yeah, I have a question here, and I hope I get this right. But which parasite applications are being used? And that's the end of the question. So I hope that makes sense to you.
Because I did mention that. So I mentioned repurposing drugs, and I can start by saying it's frustrating, the bureaucratic process, that if I came up with a new drug today that worked, it would probably be a decade before a patient would ever see it because of all the safety. And again, COVID has taught us about vaccine and how quickly you can do it. But normally it takes millions of dollars and a lot of bureaucracy for obvious safety reasons before I could release it, right? That's a new drug. But if I take a drug that's already on the market, that's already been looked at by Health Canada or the FDA, and is already used on another cancer, and I try and use that on brain cancer, that just saves all that decades because it's already gone through the process. All I've done is say, hey, maybe that works on glioblastoma. And so there's also anti-parasitic drugs. Again, COVID, you're kind of aware of that controversy, but there are anti-parasitic drugs. So, you can kind of make or understand the correlation between infections and cancer, right? So viruses, parasites, bacteria are living objects that reproduce. How do you stop them from reproducing? You give them a drug. So if the drug can stop a parasite from reproducing, you could also potentially stop a cancer from reproducing. So that's the logic. And so the drug is enflurane, or that's not the enflornithine, and it's used for sleeping sickness, which it sounds like a psychological issue, but it's actually a parasitic infection that causes sleeping sickness. So the drug that is efficacious against that is under research to be used against glioblastoma, but it's in a research clinical study currently. But it's a good example of being imaginative and creative and repurposing drugs that we're already familiar with.
Yeah. Well, thank you for that. Yeah, it just gives you quite a different understanding of, it is about, time in some of this aspects too. So if there is times, if there are drugs that have already gone through this process, so that's going to save you a significant amount of time and money.
You're absolutely right. And then, a related theme is, even if we find treatments that extend life by 6 months, some people might say, wow, that's not great. But no, but that's 6 more times of research where we'll find another drug during that 6 months, like extend another year, right? And so I think people often think we're looking for a magic bullet and we're going to say, Eureka, we found the cure. It's not likely to be the case. It'll be an iterative process, and it'll probably be a combination of therapies, the grand total of which results in cure.
Thank you. Thank you. With these new procedures on the horizon, will there be success with highly vascular brain tumors?
Yeah, I think there definitely are. A lot of the research is focused on what's called angiogenesis. So angiogenesis is the growth of new blood vessels, which almost all cancers do, and certainly brain cancers do in a very aggressive way. So again, a lot of research is specifically focused on getting rid of angiogenesis, or the vascularity of brain tumors. As you can imagine, if you can cut off their blood supply, then that brain tumor will die, just like a lot of organ systems. So there are very specific technical and drugs being aimed at the vascular supply of the tumor in a way of again, kind of decreasing its ability to invade and to grow. So both technically and in terms of pharmaceuticals, there is a specific attack on the blood vessels.
Oh, I see. Okay. And just a few more questions, because I'm just mindful of time and your time, and thank you again for taking the time to speak with us. We have a question that this person's on their second brain tumor, and it's non-malignant, but it's growing. How long should someone be, or how long, I'm trying to word this in a way that is not individualized, the wait and see method. How long should someone be on a kind of wait and see regime until you think it might be a good time to follow up?
And again, it's going to sound like I keep answering different questions with the same answer. Yeah. So the simple answer is, and I know you're thinking the same, it's very individualized, right? Yes. So you could two people can have a glioblastoma, and one's going to recur in 3 months and one will be in 30 months, even though they're both called glioblastoma. So there's more to the tumor than its general name. And so the wait and see often happens because the scan isn't clear. After surgery, radiation, chemo, the tumor area never looks normal. So it takes a lot of expertise to figure out, is that scar tissue from the treatment, or is that tumor regrowing? And it's only, for example, 4 millimeters. So is 4 millimeters of potential growth worthy of another brain operation? That's a situation where it would seem wise for the wait and see, right? With very great vigilance. Right. And so I'm giving an example of why wait and see would make sense. Mm-hmm. Whereas if you say, oh, it's there, why are you waiting? Well, it's not entirely clear that that is tumor, so that's what we're waiting for. And again, through my own personal experience, I reassure the patients, if I'm wrong and it's not scar tissue, even if it grows from 4 millimeters to 8 millimeters, it'll take me the same 10 seconds to remove that at surgery, right? So even if the 4 millimeter tumor doubles in size, I can get rid of it just as quickly. That's why it's not so worrisome to wait and then see that you're wrong. Right. So there are different reasons why wait and see is deployed, even though it might feel like, what are you talking about? Wait to see if the cancer grows. That's very unsettling. There are very nuanced reasons why it could be more harmful to act prematurely, and rather just be cognizant that the options remain on the table, but we just want to be sure that they're deployed safely.
Right. Great. Well, thank you again, Dr. Toyota, for taking the time and speaking with us today. There are many more questions here, but I'm not going to be able to get to all of them. But there are also some kind comments that says, I thank you, Dr. Toyota, for bringing hope to all. And there's one that says, I've worked in the neuroscience unit in St. Paul's Hospital in Vancouver when you were there in the early 1990s. And great to see you, and thank you for taking this time. Yeah.
I'm always happy to come back, Todd. We can do a whole hour of Q&A if you like, and I'm at your disposal.
Oh, that would be wonderful. Thank you so much, Dr. Toyota. I really, really appreciate this time.
Thanks for your invitation.